So let's kind of talk about some more of these things with trauma and talk about head trauma itself. And kind of one of my favorite topics, especially working in flight. We do a lot of these, which usually means procedures for those of us that enjoy those. But trauma, for the most part, is pretty simple. It's ABCs, but then sometimes it's those minor patients we have to think about that really make us work for that money to figure out, hey, is this patient something we need to do more with, or is this somebody we can just watch and wait? So definitely we know we unfortunately live in a litigious society. We do have some really good clinical decision tools out there to help us in deciding what patient needs what. Especially when we talk about pediatrics. Should we be getting imaging of their head, or should we just do observation, or just good education? So definitely we know that our patients with head injuries can present with various things. They may be the typical, straightforward, obvious head trauma. They're altered, they're confused. But it may be something more subtle, like just they're amnestic to the event. Or maybe they have other type of neurological deficit or sensory loss that we have to kind of identify and tease out. A patient I had just the other day had a head injury, pretty minor, but it was amnestic as ever. And totally, that patient that we love so much that every 5 seconds asking me the same question over and over again. What happened? Where am I at? Who are you? And just kept going. And that sometimes is challenging because now I've got to figure out, is this truly just a mild TBI or does he have something else going on? So just kind of keep that wide range of suspicion out there that if they had this head injury, maybe it is minor, but maybe it's major, and let's rely upon our physical exam findings and even the history of the event to kind of help guide us in what we need to do with this patient. So very common in our young male population, especially in the Caucasian males, and usually involves the, hey, y'all, watch this, hold my beer. Those are famous last words for a lot of the patients I see, especially this time of the year. But what do we see? Is it major trauma? Is it minor trauma? Major's pretty easy. And then thinking again about those minor things to make sure we don't overlook something. I don't want to kind of get anchored down, oh, hey, it's just a minor head injury. Let's not miss something. We know that scalp lacerations can bleed a whole lot, very vascular, and sometimes just that smallest little nick can make it look like they've got a very large laceration. And especially in our older patients who are probably anticoagulated or antiplatelet agent, that tends to make it even more difficult to control. But direct pressure should always be our first intervention. If I can, go ahead and throw in a stitch or a staple, or if you have some of those cool little devices that can crimp the tips of the wound edges. Go ahead and start anesthetizing those with lidocaine or Marcaine with epi, and that can sometimes really help. We've got combat gauze that we can use now, some of those thrombin-impregnated pads that can work, but definitely we know that patients can sometimes lose a lot of blood and become hypovolemic just from that head injury. Always a good idea when they're moving them over from the EMS stretcher to your bed, what does it look like? And tons of these have that little center groove down the middle, and it's full of blood. Patients bleed out all kinds of places, and one of those is on the floor or on the stretcher. So get an idea, how much they lose, is it significant or not? If they're closed head injury and they're hypotensive, look for other things as well. Most of our patients with head trauma have multi-system trauma. So maybe it's chest, maybe it's pelvis, but definitely always have that suspicion if they already are hypotensive, where is that blood at? Is it somewhere else? And we know that one single episode of hypotension, one single episode of hypoxia can be detrimental to the head patient. That's one of the first two questions we usually want to know. Is there any history of either one of those? So that definitely increases their chance for having some complications and increases their mortality. So the Glasgow Coma Scale is an old tool. It's been around for quite a while. It was originally developed for EMS to kind of triage those patients and get an idea about how severe this injury was. But it definitely has some benefits for us as well. We know if that patient comes in, their GCS is 14 or 15, they're early from their trauma, that's a pretty good indication of a good neurological outcome. And some of our clinical decision tools will look at this as well. But if they have a GCS less than 14, then this patient may have some type of moderate or mild brain injury. And the lower that number gets, the more severe that brain injury is. Now, to take into consideration that the GCS does have some limitations. I'm looking at their best eye movement, their best motor response, their best verbal. But obviously, if they're intubated, I just lost all their verbal. Or if they have some mid-face trauma, they have a lot of periorbital edema, I may lose the ability to assess that as well. So it does have some limitations, but we can definitely use it to trend and to quantify that. Hey, this patient that came in with a GCS initially of 15, and 2 hours later their GCS is still 15, that's a pretty good indication of probably not a significant neurological injury. But that GCS initially of 9 or 10, and it's still 9 or 10, or it's decreased even more, that really makes me concerned about something else that's going on. I need to look further and anticipate this patient may require a lot of interventions. The old adage of GCS less than 8, we intubate is still pretty accurate. Again, take every patient into consideration. What's going on? Why is their GCS less than 8? Maybe it's because they have facial edema and I can't see their eyes. But probably if they've got a GCS less than 8, that's significant of a severe brain injury, and that patient likely cannot control their airway, cannot protect their airway, and we should look at controlling it earlier versus later. Skull fracture we run into frequently. Typically, luckily, most of these are usually linear. They're usually not depressed. They don't require anything else than observation. But definitely if those patients have a high-risk fracture, a depressed skull fracture, or a Bayesian skull fracture, then those are likely to need more intervention and have a higher risk for having underlying trauma, laceration of the dura, risk for infection, risk for hemorrhage. If I have a patient with a temporal bone fracture, those patients have a higher incidence of having an underlying injury to that middle meningeal artery, and that's almost a common site of an epidural bleed. So that soccer player, that player who complies with someone else, you get imaging, they've got a temporal bone fracture. That patient definitely has that higher incidence. And if they already have an epidural bleed, this is probably your number one site for that. So just have that index of suspicion for those patients. Definitely if it is open, if it is depressed, then that definitely is going to be a neurosurgical consult. Most will go ahead and recommend prophylactically treating them with antibiotics, especially if there's a significant laceration there for that risk of developing some type of infection of the meninges. Temporal bone fractures sometimes be kind of subtle. Definitely our CTs are much better than they were 20 years ago. We don't have to use plain films like we used to, but definitely if that patient has that, have that high index of suspicion, getting neurosurgery involved, definitely considering this person over somewhere else for observation if I don't have those resources there at my facility. And that classic Bayesian skull fracture, which looks like we don't see as much as we read about, but those classic findings that we'll run into, the battle sign, the raccoon eyes, looking for that drainage from the eyes or the ears or the nose, make us very concerned for problems that we'll see there. If they have that concern for Bayesian skull fracture, I have risk for cranial nerve involvement. They may have some hearing deficit or may have some facial numbness or may have some of the other cranial nerves that are involved also. Most will go ahead and recommend prophylaxis for antimicrobial therapy. There's not really good evidence supporting that, but one of those things that's kind of kept going on for the years. But definitely we know that they do have a CSF leak. That patient is higher risk for meningitis. So probably go ahead and cover them with some higher generation cephalosporin or maybe in vancomycin if we're worried about community-acquired MRSA being at risk, to go ahead and cover those for that. Luckily, most of these CSF leaks resolve in about a week, but luckily if they don't resolve, then those do have a higher risk for complications. If they've got that clear drainage from their nose or their ear, and I am worried about CSF, go ahead and check it for glucose. Have them get it on your glucometer strip, check it to see if there's glucose there. And if there's more than 30 milligrams per deciliter on that clear drainage, that is cerebral spinal fluid. If I got that nice blood-tinged fluid, then we can do the halo test or the ring test as you see here. And if I get that nice separation out and I have that little halo appearance outside that blood, that is cerebral spinal fluid. This patient likely does have that Bayesian skull fracture, so an increased risk for infection, increased incidence of seizures, and they need closer observation. And actually, if we're not really certain, we actually can send that fluid off. They'll do a beta transferrin, a test analysis, and that will truly confirm if this truly is cerebral spinal fluid or not. But just have that index of suspicion. If that patient's like, I just feel like I got postnasal drip, they're just constantly clearing their nose, like they're swallowing stuff, that probably is CSF and needs further evaluation. The raccoon eyes, the battle signs, classic textbook things that we sometimes see. Raccoon eyes are pretty common. We'll see those frequently from assault victims, from other types of trauma, and raccoon eyes usually show up pretty quickly. They're not always going to tell us they have a Bayesian skull fracture. It may just simply be from localized trauma, but they have a higher incidence. The battle sign, though, doesn't show up very quickly. So for most of us in the ED, we rarely see these. These are what we see, hospital day 2, hospital day 1, when they've been admitted for this. But where I have to be concerned here is that patient comes in, trauma, and they already have bruising behind their ears. What's the story? When did this trauma happen? That kid that just fell off the bed won't have bruising behind his ears that soon. This takes 12, 24 hours for the mastoid process to absorb that blood and for us to see that bruising. So just be kind of concerned that if your story doesn't match the presentation, we have to worry about things of non-accidental trauma, unfortunately. Battle signs, those take a little while. Raccoon eyes, usually in the first couple hours, we'll see those more frequently. Do I see that hemotympanum? It's really important for me to document the presence or the absence of that when I'm worried about these head injury patients. Get a good look in their ear. What do I see? Very common, we'll see blood coming out of the canal, but where's it coming from? Is it truly coming into the canal, or is it just blood from something else that's leaked in the canal? So clean that area out and then document, hey, hemotympanum was present or it was absent. And definitely if I'm seeing truly blood behind that membrane, that is an increased instance of having that basilar skull fracture also. So what was the mechanism? Was it blunt trauma, which is one we see the most? Penetrating trauma, definitely usually more obvious, but if they've got that GCS less than 8, think about this is a significant injury. This patient probably does need to have their airway controlled. That way we can maximize their oxygenation, give them good gas exchange, and hopefully prevent complications. Our goal there is to keep them normoxic. As was talked about earlier in the ACS lecture, we shouldn't be giving everyone oxygen just because they need it, because they don't always need it. We know that O2 is really good, but hyperoxia causes vasoconstriction, and that can worsen neurological outcomes. See that a lot with stroke patients, the same with ACS patients for the heart. Our other goal is also to regulate their CO2, and we want to keep maintaining normocarbia there. We used to, years ago, we'd intubate them and we'd bag their CO2 down to nothing, trying to protect the brain. And really that's not very helpful. If we need to do a hyperventilation, we can do it, but it should be a controlled hyperventilation, probably keeping their end-tidal CO2 or their PCO2 somewhere between 30 and 35. Normal 35 to 45, let's keep it just a little bit low. That'll have some cerebral protection to it, but not be detrimental. If we need to secure their airway, rapid sequence is still our best tool. It definitely improves our first attempt success rate. For induction, probably most of us are going to either use etomidate or ketamine. Ketamine, for years we were told, don't use it with head injury, it increases ICP. That evidence has been disproven, and probably for most of us, ketamine is our first-line agent now for rapid sequence intubation. The nice thing about ketamine is it gives us analgesia and sedation, which none of our other agents do that. Etomidate is also a good option. The big thing about etomidate is that it's intended for one-time use. Etomidate may cause some adrenal suppression, so if I give it once, I shouldn't use it again for 24, 48 hours. But ketamine definitely is a good option. We know that using short-acting paralytics can also improve our first attempt success rate as well. We get our imaging, get neurosurgery involved as soon as possible. But think about the need for medical decompression. For years, mannitol was a great drug. We used it a lot. Good osmotic diuretic, would help pull out fluid, reduce ICP, but then it caused that significant diuresis. And especially for isolated head patients, that may be okay. But in multi-system trauma patients, that could be detrimental. So a lot of us have kind of gone away from mannitol and more toward hypertonic saline. And there's been several studies that compared both. Probably hypertonic is a little bit better and probably has a longer effect on reducing ICP compared to mannitol. And I don't have to worry about that diuresis and that hypovolemic risk. And there actually was one study that looked at doing either mannitol, hypertonic, or a combination of the both, and actually found that using a combination of both actually was better. But then it gets really difficult in trying to figure out how much of each one to give. But either are effective, but probably hypertonic is a little bit better, especially in those patients with multi-system trauma, so we don't cause that hypovolemia. We probably go ahead and treat them prophylactically for seizures. There's not really good evidence for that, and some places have gone away from that, but probably things like phentoin or phosphentone or levetiracetam are just as effective as anything else. One of the nice things about all three of those, they tend not to be sedating, so that tends to be our first goal, and usually that's for a 7-day course. And then what really makes it fun and challenging is when they're anticoagulated or when they're on antiplatelet agents. And we'll come back to that shortly. So epidural bleeds, one of our common bleeds that we run into. This usually is arterial in nature. Classic one is those two players that collide. They get that temporal bone injury. They get that injury of the middle meningeal. Since this is arterial in nature, it's usually a very rapid change in mental status. For years, we were talking about that classic concussive event that we would see, and this person would have that classic lucid interval where they would get knocked unconscious, they would wake up, they would be lucid, but then they would rapidly go out again. That's not always there. Sometimes they get knocked out and they're totally out for the whole period. But either one of those can be presentation. But just keep in mind, this is usually that very rapid change in mental status. And that's the ones I'm really concerned about. They have about a 50% mortality rate. Because if we don't recognize and intervene early, they're definitely going to cause significant shift and potential herniation syndrome. What we'll see on the CT, as you see here, is that classic biconcave look. Looks like you're kind of looking at the contact lens of an eye. And this definitely can cause rapid accumulation and rapid shift. Where our subdural is venous in nature almost always. It's one of those bridging veins that tears. So usually their presentation is a little bit more gradual, a little bit more subtle. This is your usually older patient, your alcoholic patient, but definitely could be any patient depending on the mechanism. But they have a head injury, a little headache, maybe a little dizziness. But as the day progresses, so does their complaint. The headache gets worse. Their mental status changes even more. Their dizziness gets worse. Definitely our older patients, our alcoholic patients, our malnourished patients, they're at higher risk because of brain atrophy. As we get older, our brain gets a little smaller. If we drink a lot, our brain gets a little smaller, and it tends to be more mobile. And during that head trauma, it tears one of those bridging veins. And with these patients, we'll sometimes see them in different phases, that acute phase versus that subacute or even chronic phase. And for patients that fall a lot, it's common to see kind of a mixture of all three of them, or sometimes two of them. And you get the report back, or you look at it like there's old blood, new blood. So patients that fall a lot, our Parkinson's patients, our alcoholics, those that fall a lot tend to have a higher incidence of having these. And on that CT, it has that crescent shaped. So why does our subdural versus our epidural look so differently? Where's the bleed at? On top of the dura gives us that very convex look because the dura attaches the skull, and it's attached at points here. And when that blood collects, it can't go anywhere else, and it gets confined to that space, and that usually causes that significant buildup of ICP. Where our subdurals underneath the dura, there's no connections there, and the blood just kind of goes across the surface and gives us more of that crescent look. And usually it's a slower onset of symptomology, but it can be pretty significant. It's common that patients may have both, but as a good rule of thumb, subdurals and epidurals are traumatic to proven otherwise. People don't just walk around and get a spontaneous subdural or a spontaneous epidural. Those are trauma to proven otherwise. They're usually not medical. And even that subdural, even though it's more gradual, even though it's slower, can definitely have a significant buildup and start causing that midline shift. And that definitely increases their risk for herniation. But these also have a higher mortality because they're more slow and more gradual. That person falls, has a head injury, and it's 12, 24 hours, sometimes 36, 48 hours before they seek medical care, and by then they've already had such significant shift, that's caused a herniation syndrome. So both can have that high mortality. We need to be suspicious for them and definitely consider getting these imaging, especially if our clinical decision tools kind of guide us in that direction. And then occasionally we'll see people that have those intracranial hemorrhages, and it's just intracerebral there somewhere in the brain parenchyma. These could be traumatic or medical. Here we're talking about the trauma ones, but definitely this here also can cause problems because it builds up and causes ICP. Just like all these others, it's going to decrease blood supply to certain areas, so we're at risk for ischemic injury as well. And our big concern anytime we're talking about this increased intracranial pressure is the risk for herniation syndrome. That is a very tight, closed box. Inside the skull, finite amount of space. We've got our brain tissue, we've got our blood, we've got our CSF. And if we change any one of those three, we're going to affect the others as well. And our two big ones we usually have to worry about are going to be our uncal herniations and our central herniations. So that classic uncal herniations, they herniate there on one side as you see, indicated by number 1. That's your classic patient who blows a pupil. You're evaluating and all of a sudden, pop, they blow a pupil. That's a classic uncal herniation. They may blow both pupils, and they've had now bilateral uncal herniations. Where your central herniation, that's right down the center as you see there illustrated by number 2, and that's your classic pinpoint pupils. Both pupils are very constricted, they become non-reactive. Our treatment for us is pretty much the same. We've got to reduce their ICP. Think about simple things like getting the head of the bed up is really important. Just getting the head of the bed up, keeping that neck in neutral inline position is really important for helping prevent, but also treat intracranial pressure. If they're in a C collar, trying to keep them in neutral inline position. If they're immobilized and you can't get the head of the bed up, reverse from Dellenberg the bed. Just getting their head up a little bit improves CSF drainage, improves venous drainage down, so that we can hopefully prevent this syndrome from happening. But these patients are going to require medical decompression and likely are going to require surgical intervention as well. So our concussion, and nowadays a lot of texts are going to refer to this as a mild TBI and not a concussion. And that's kind of the shift because it truly is a mild traumatic brain injury. And that kind of emphasizes to the patient, family, whomever, that this is not just getting their bell rung, as we used to say. It truly is a mild traumatic brain injury, and we know that recognition of this risk and hopefully prevention of these risks that we can see with a TBI are really important. So that classic concussive syndrome, the person comes in, they had a head injury, like my guy the other day, concussive amnestic as can be. Every freaking 2 or 3 minutes he was asking the same questions over and over again. That's your classic concussive syndrome. But nausea and vomiting is also common. They may have some dizziness with it. They're going to have that amnestic property. They don't recall what happened, and they have those repetitive questioning. They have a normal CT scan of the head. An MRI might show some subtle changes, but the CT doesn't. This is a non-focal injury. It is getting their head wrong, but we know that it's more important than that because it is truly a mild TBI. Luckily, most people with a mild TBI, their symptoms fully resolve in about 24 to 48 hours. But what some people may develop is this post-concussive syndrome, and their symptoms may last for up to 3 weeks. So for the next 3 weeks, they have a headache, dizziness, nausea, vomiting, sometimes some vision changes, and that can be reproduced by other events as well. But luckily, after about 3 weeks, it goes away. But our big concern is this secondary impact syndrome. So we know that getting the head injury increases the risk for other problems. And that's when we really want to focus on education of these patients, their parents, if it involves sports, those that it's really important for them to get good rest. So until this person is symptom-free, they should not go back to contact sports. They need cognitive rest. Yeah, we want them to rest, but they need a cognitive rest as well. No video games, no computers. Let your brain rest. It needs to. That we know that people that have a traumatic brain injury, and if they have another traumatic brain injury before their symptoms are resolved, that's when we get this secondary impact syndrome. And what happens now is they develop cognitive defects. Their attention span drops. Their IQ actually gets less. And the more head injuries they have, the worse this gets. And we end up seeing is the development of traumatic encephalomalacia. And the only true way to diagnose it is by autopsy. But we definitely see that with some of our really professional sports activities. Our athletes are high risk for this, and some of them have donated their body to science for studying this and find they have significant brain atrophy from these repetitive head injuries. And there's some pro sports people out there that aren't right anymore. It's because of this repetitive head injury. And so it's really important we get them to understand they need that rest. It is not just a concussion anymore. It is truly a mild TBI. And these patients need rest, they need cognitive rest, and they need to be cleared by someone else before they go back to contact sports, before they go back to activities that has the risk of getting another head injury. We have neurologists and neurosurgeons that focus just on this, ophthalmologists that are involved just in this. In my institution, we have a concussion clinic, and that's where we refer all them to for all this evaluation so that we hopefully reduce this risk of that secondary impact syndrome. Education is really important. And luckily now, most of our schools, sport agencies, they're really on board with this because it's made a lot of national news. But a concussion is a traumatic brain injury. Hopefully it's a mild one and one that we can limit those risks for complications down the road. So our clinical decision tools, I like to call them, there's several out there, and these can be really helpful in helping us determine who needs imaging and who doesn't. So this is the Canadian Head CT rules. Here are the inclusion criteria, so who wasn't included in the study. So if your patient fits one of these, I cannot use this clinical decision tool to make that decision whether I obtain a CT or not. And there are several studies that have demonstrated that Gestalt is as good as these clinical decision tools, but use these. I use this a lot to explain to patients why or why not we need something. But for this tool, they can't be less than 16. They can't meet any of these other criteria. But what these clinical decisions tools do is help us identify those who have the risk for a clinically significant injury. It may miss minor things. It may miss people that don't need neurosurgical intervention. Our goal here is to identify those who do. So the high-risk patients, those people that we should get CTs on, if their GCS is less than 2 hours after the injury, they're not back to baseline, we suspect they have an open or depressed skull fracture. If there's any obvious signs of a basal skull fracture, if they've vomited 2 or more times, or if they're over the age of 65. Those people need imaging, unless it's been minimal trauma. Those people, and this was 100% sensitive for identifying those that have a significant brain injury that needs intervention. We also have some medium criteria here. So amnesia, what was the mechanism? Use your gestalt, use your clinical decision-making skills with your patient or your family, and discuss those. Hey, and most of the people, I'm not worried about getting a CT and risk for cancer in their 65 years already. It's the younger people I'm worried about. But using this clinically significant tool can help us determine, yes, I need to get imaging, or no, I don't. And then include that in medical decision-making. So there's just a nice little picture for you. If you don't use any of these clinical calculators like MD Calc, it's simple. There on your phone, or go to your favorite search engine and search for it, and it'll go step by step looking for different things to go, yes. And they kind of give you the risk. This person has a less than 0.9% risk of a significant brain injury. This person has a 5 or a 4. And you can use that in your decision making and that shared decision making with your patient. We also have the New Orleans criteria. So here are the inclusion criteria. So who we can use this tool to determine. And if this person has no headache, no vomiting, they're not 60 or older, no seizure, no intoxication, no retrograde amnesia, no trauma above the clavicles, that patient likely will not need a CT of the head. Again, we're looking for those clinically significant injuries. It might miss something, but it's probably something that will not need intervention. Go through your skull. Discuss this with the patient. So I mentioned these earlier, but definitely we know that our anticoagulants can be very problematic in trauma. We deal with them a lot, and definitely with head trauma and our older patients, this definitely can be problematic. For years, all we had was warfarin. That was easy. I can reverse it pretty quickly. But now that we have a lot of our factor Xa inhibitors, we have our direct thrombin inhibitors, that's become more problematic. Warfarin works at multiple levels. It's going to affect all those vitamin K dependent processes, but I can fix this pretty easily. We can give vitamin K, we can give either a PCC or plasma. And looking at most of the studies, the prothrombin complex concentrates are superior to plasma when reversing a vitamin K antagonist. The nice thing is also a lot less volume. Instead of giving large volumes of fluid, I'm giving a smaller volume. So if you have it available, currently Kcentra is the only one that's FDA approved in the US. There's probably a benefit of using Kcentra over plasma for reversing warfarin. They still need to get the vitamin K. If they have a history of HIT, then you can't give them PCC because it actually contains some heparin. I actually learned that not too long ago with a patient we had that had a history. Didn't know that one. But warfarin's pretty easy. But at our newer ones, those are one more problematic. Now we do luckily have reversal agents for all of those new agents except for edoxaban. If you have them available, they do work, but they're fairly expensive. And they're indicated in patients who have life-threatening hemorrhage associated with the use of that anticoagulant. And probably in our trauma patients, that's one we have to consider. There may be a benefit of giving them something else, like a PCC or plasma, but may not benefit. Use your resources, talk to your pharmacist, talk to your trauma surgeons, and see what's going to be the best for this patient. Minor trauma, minor bleeding may be great for observation, but definitely they're having significant hemorrhage, they're on one of these agents, consider your resources, and do I have access to these to reverse those people. Antiplatelet agents, a little different. There's a mixed evidence out there of actually giving them platelets works or not, and probably most nowadays probably say there's not a benefit unless this person already needs to go to surgery because they're already going to have a low platelet function. But we know that people on anticoagulants and antiplatelets are at risk for bleeding at the trauma, but also risk for subsequent bleeding hours after the trauma. And those are people I might consider observing for longer, or repeating CTs in 12 or 24 hours, looking at the evidence. But definitely they're actively hemorrhaging, it's major, consider your reversal. People on warfarin, it's easy. I can get a PT-INR pretty quickly. Patients that are on other drugs, I might be able to get something from that PT-INR. If I have the ability to do thromboelastometry, I might get a benefit from that as well. One of the nice things about thromboelastometry, Rotem, Roteg are the two big brand ones. It takes all these medications and looks at it and tells us what we need to do with it. And those can be really helpful in some of these trauma patients in determining what I need to give to reverse these. So here's a guideline that was, or actually a summary of some guidelines that was put out a couple years ago by one of my colleagues at Vandy. And this kind of gives you a good summary of what to do with these different agents. And then lastly, our kids. What about our kids? And there's been several clinical decision tools out there. Probably PCARN is the one that's been most studied and most validated. It included over 42,000 kids in that study across multiple institutions. But definitely there should be some shared decision making with the patient if they're old enough, if the family, discussing that, hey, imaging is great. Luckily, our CTs are much better than they were 15, 20 years ago, but I have to worry about the risk this patient may need to require sedation to get a good image. And we know that ionizing radiation was not without risk, and that some young kids will develop cancer from that imaging than we did when they were younger. My older patients, I'm not concerned, but definitely my younger kids, let's look at the risk and benefits. Let's have that shared decision making. If this kid looks okay, maybe observation is the way to go without doing the imaging, especially if this is going to require sedation to get a good image. These tools are out there. They're not as good, but they're better than what we had, which was nothing. And probably PCARN is the one we're going to look at the most. So PCARN, as I mentioned, 42,000 kids were involved in this study. They were only looking at trauma, so that's what we're going to look at here. Their exclusion criteria I've got listed for you here, but those who we cannot use this tool for. If it's not trauma, if they're over the age of 18, if they have penetrating trauma or they've already been evaluated somewhere else and already had a CT of their head for this trauma, then we can't use these tools. And they break it down based on age. So is this kid less than 2 or is this kid over than 2? And looking at these guidelines, if this kid is under the age of 2 and they're altered, they have a palpable skull fracture, LOC more than 5 seconds, they're not acting right, a non-frontal scalp hematoma, that person probably would benefit from getting an imaging. The top 2 are the most important. If they have either one of those top 2, altered mental status or palpable skull fracture, their risk is about 4 to 5%. If it's one of the others, it's lower, less than 1%, and that might be the patient that I might think more about observation versus imaging if I have a low suspicion. But based on these guidelines, these are pretty good to give us guidance of, yes, this kid needs a CT versus this kid doesn't. And then those are 2 age and older. Again, altered mental status, basal skull fracture, again, those are the 2 most important ones. If they have either one of those, somewhere around 4 to 5% risk of having some intracranial injury. The other one's much lower, but things we should still consider. And if they meet one of these or they need more than one of these, this is the patient I definitely need to lean towards getting advanced imaging versus observation. But have that discussion with the parents. The kid fell off the couch, they fell off the end table, they're acting normally, they have a little bump here on their forehead and nothing else. That kid probably doesn't need anything but observation. Share the information with them, give them the statistics, give them the percentages. But these can definitely guide us in determining who has the risk for a significantly brain injury that requires intervention. Again, just like adults, these might miss some things, but they're considered to be minor. We're looking for those clinically significant injuries that would benefit from neurosurgical evaluation. Use your clinical judgment, compare it back to what these guidelines tell, have that shared decision making. If parents are really concerned, then let's do what's best for the patient. But share that, document that in your medical decision making. And if all else fails, clinical observation is totally appropriate. Just like for older adults, those on anticoagulants, hey, let's observe them there in the ER for a couple hours. If we need to, then hopefully an inpatient admission for observation. But these clinical decision tools may be helpful. There's the image there for your PCARN. Again, these are available in a lot of your apps that you can use. MedCalc is just one of those. But use those to kind of help guide your care. But go through your gestalt as well. If your gut says do it, that's probably a good indication because our gut tends to be right most of the time. All right, thank you very much.